Evening, doctors. Welcome to the third episode talking about the diagnosis of the non-odontogenic toothache. We talk about the mechanism of pain, what are the receptors that are responsible for the pain sensation. We will discuss the sources of odontogenic toothache and the sources of non-odontogenic toothache. To finish, we will finish the chapter by discussing two cases to know how to diagnose this type of pain. Have a good watch. First of all, what is pain? Pain arises as a result of tissue damage, which means when the tissue is getting hurt, it sends messages that we are having a problem. These messages are detected by special fibers. We have two types of pain detect fibers, which are the A delta and the C fibers. They have different types of pain sensation. Let's talk about first the A delta fibers. They have faster conduction velocity. They are faster than the C fibers, and they transmit sharp or pricking sensation. As for the C fibers, they have slow conduction velocity, and they have a higher threshold for the pain. They are associated with dull or burning sensation. C fibers are the main fibers in the pulp, so the pulp, and they are rarely found in the dentin. After knowing the two types of receptors, let's talk about what are the sources of the odontogenic toothache, how these receptors have part in the pain sensation. The two main sources are the pulp dentin complex and the periradicular tissues. As we said before, that the C fibers are the primary nociceptors in the pulp, so they are the main fibers who respond for the inflammation, and they conduct the pain, and they are rarely found in the dentinal tubules. Something to take perspective of that when there is an inflammation that actually is prolonged in time, the C fibers threshold pain becomes less, and they can be as sensitive as to respond to the normal pressure of the cardiac contraction, which means that the patient can feel that the heartbeat in his tooth, or he may say that my tooth is throbbing, or they can reach to a point where they can even fire without any stimulation, which means they can cause pain which is spontaneous. So they are the reason for the spontaneous pain, which means it is the degree of the non-reversible pulpitis when the bacteria has reached the pulp tissue. If you remember, we talked in the chapter of diagnosis what is something called the referred pain. Referred pain, the reason for it, referred pain, what is its definition, which means that we have a source of pain in an area, and the pain is felt in an area that is far from the source of the pain. In our case, for the tooth, we said that it happens mostly in the mandibular area, and especially in the posterior mandibular area, where the neurons of the mandible teeth converge with those of the maxillary teeth, which results in the referred pain sensation that the patient can say that he is feeling pain from the maxillary arch, where the source of pain is the mandible. This is regarding for the pain that is from the pulp. Now let's talk about when the bacteria reaches the periradicular area, and we have an periodontal ligament inflammation. Here, the patient has the ability to detect the source of pain more precisely because we have so many mechanoreceptors that are located in this area. As we said in the diagnosis chapter, that we have the percussion and the biting tests are helpful in knowing the periodontal ligament inflammation. Now, what are the sources of the non-odontogenic toothache? There are three main sources, which are the muscles, the nerves, and the sinus. We start things up by talking about the myofascial pain. The myofascial pain emanates from small foci of hyper-excitable muscle tissue. These areas feel like bands or knots and are termed like trigger points. These are the trigger points, which are the dense muscle fibers that becomes more sensitive to pain. They can be formed naturally by getting older, or they can form by wrong postures or heavy carrying of things, and the pain varies in its strength. When we hear about the Chinese needles, they are actually triggering these points to make them loose, or some of them use the massaging to stretch these knots and relieve the pain that the patient often have. So these are what are the trigger points. When we have a problem in the muscle, the patient may report that he has pain in chewing, which means that the mastication muscles are responsible for the pain of this type. The pain is triggered by contraction of masticatory muscles, and they can be indicated by the palpation. When we pulp these muscles, they reproduce pain, but when we remove the palpation, the pain goes, which means that this pain is predictable, and this is not the case for the pain of the tooth, when it can be spontaneous and it does not have this periodic cycle of pain or trigger. The most muscles that refer to this pain are the masseter, the temporalis, and the lateral pterygoid. You can watch videos on how to clinically examine these muscles, whether it is extraorally or intraorally. There is something that we need to take perspective of, is the correlation between the toothache and the muscle, which means that toothache can trigger the pain of muscles, and muscles may have the same pain that is so similar to the pain of tooth. This can actually be really frustrating for the clinician and for the patient, which means that the dentist can finish the restorative procedures regarding the teeth, and the patient still suffers from pain, which there is the source of it are the muscles, because the muscles need time to go back to their original state. So what do? We have the spray and stretch mechanism for the muscle relaxant, and we have the trigger point injections that we spoke before that are used for these trigger point injections are used for both the diagnosis and the treatment. Here they are saying that the efficiency of the trigger point injection varies. Some patients might experience lasting relief with one injection or several, whereas others may not. So it is a dependable experience. When we are going to discuss the cases, I think the picture will be more obvious on what are the signs that are related to the pain sensation of the muscle. So bear with me. Now let's talk in brief about the pain of sinus or the nasal mucosal origin. This pain is another source of pain that can mimic toothache. The symptoms are fullness or pressure below the eye. We can trigger the pain to know that the source of it is the sinus by asking the patient to lower his head down, and this pressure will make pain and tell us the diagnosis that is a sinus origin. When the sinus is in inflammation, is in its acute stage, we can see that we have nasal obstruction, or facial pain, pressure, fullness, or nasal discharge. When we do palpation for the area under the eye, we can feel the toughness and the pressure associated in this area. So if we suspected that we are dealing with a sinusitis, the patient is referred to this one, if you can read it, 𝒤𝒊𝒂𝒂𝒊𝒂𝒂𝒊𝒂𝒂𝒊𝒂𝒂𝒂𝒊𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 who is dealing with this, with the nasal and the larynx and the ear, to do more diagnosis and determine what is this the source, the etiology, whether it is bacterial, viral, allergic, or obstructive, and to prospect the and to write the appropriate treatment for the patient. Now let's talk about the neural source of pain. The neural source of pain are this the neural pain source is mostly from the trigeminal nerve, and most commonly people report pain presenting in the forehead, the back of the head, the temples, also the jaws and the teeth. Taking the medical history is really important to know the patient is already suffering from headache disorders, like migraine disorder, because these type of patients are most likely to have these type of neurovascular disorders. They're saying here that non-steroidal anti-inflammatory medications may really relieve this kind of pain. The neural pain is intense, sharp shooting pain, and it is most often unilateral. This is important to take perspective of. It is unilateral, and it is associated with normal facial gestures like smiling or doing lips movement, speaking. The sharp shooting pain should alert the clinician to consider trigeminal neuralgia in the differential diagnosis. In general, these individuals should be referred to a neurologist or orofacial pain oral medicine clinician for a complete diagnosis, workup, and treatment. Why? Because 15 to 30% of patients have a secondary reason for their pain, such as brain tumor and multiple sclerosis. The patients are usually older than 50 years, and if you have they have cardiovascular problems, these the blockage or the constriction of the arteries around the trigeminal nodule can make trigger of it and cause its this kind of pain. So taking the medical history can really ease and make our ease things up for our differential diagnosis. Carbamazepam is one of the most common medications for this kind of neural problem with vitamin B complex. The damage to the nerve. Now let's talk about damage of the nerve in that may happen during doing our dental procedures, like extraction or implantology, or when doing an endo-obturation and substances like the hypochlorite and pharmaclizor or the ogenol gets out to the radicular area, the periradicular area. This can cause an inflammation of the neurons in this area. The symptoms may develop in a range of 10 days after the event, and having the appropriate and fast diagnosing with appropriate and actually fast providing the right medications as fast as possible really plays a role in the prognosis of the situation. Here we can see the extrusion of the filling that is followed by sharp burning continuous pain. You can see how much the burning sensation is really associated with the nerve injury, and this pain was continuous pain that could be made worse by a light touch of the tooth, and it can be associated with aberrations such as paresthesia, dysesthesia, and anesthesia. The pain provoked is disproportionate to the stimulus, which means that small stimulus can cause high intensity pain. Here are saying that some viruses can, like the herpes zoster, can be involved in the trigeminal nerve inflammation. Now let's discuss two cases that will makes us have a better vision. Here they are saying that the muscular pain is dull. The neurogenic is burning. We must know the type or the type of pain we are dealing with. It is critical to gain knowledge of any prior consultations that have occurred. Details regarding the type of clinician, actual workup performed, and diagnosis rendered will help to narrow down a differential diagnosis. Case 1. And let's be aware of all the details that are we are going to say. The patient is 56 years old. The chief complaint is usually written in the patient words. He's saying this tooth still hurts and it's getting worse. It even hurts when I smile. He has a history of angina, secondary to a 70% occlusion of his right coronary artery. He is suffering from hypercholesterolemia and he's taking several medications. He had a root canal treatment and 𝒒𝒊𝒂𝒈𝒏𝒐𝒕𝒊𝒂𝒄 root amputation on tooth 3. This is the peripheral radiograph showing prior non-surgical root canal treatment and 𝒒𝒊𝒂𝒈𝒏𝒐𝒕𝒊𝒂𝒄 root amputation with this deep pocket that was measured for 8 millimeters deep, and it has a horizontal bone loss. It is usually associated with this type of this age, for some people, not for all. As a first glance, it was became apparent that the patient is experiencing pain of two different qualities. Ache associated with tooth 3 was sharp shooting pain, also associated sharp pain, and the other pain was gradual onset 9 months ago. We're saying that the gradual increase of pain is an indication that we're dealing with a non-odontogenic pain. This pain is aggravated by biting or by the occurrence of the sharp shooting pain. He is saying that it occurs spontaneously when the patient is smiling big, or by pressing lightly on his face in the area overlaying the tooth, but not by pressing intraorally. As we say that there's a correlation between the toothache and the non-odontogenic ache, and we can see that they are actually in the same place. As for examination, the intraorally, we have no cracks or fractures, sinus tracts or swelling is detected. When probing, we saw that there was a defect of 8 millimeters with bleeding when probing. We said this. So, what was the diagnosis? The diagnosis was trigeminal neuralgia and advanced localized adult periodontitis of the same of tooth 3. The patient is referred to a neurologist for evaluation and treatment. Diagnosis of the trigeminal neuralgia is confirmed from the neurologist, and he is placed on a carbamazepine at 100 So the ongoing, the pain that is gradually increasing, the pain that is spontaneous, that fires sharply with doing um, with doing normal gestures like smiling, or by small pressing, when we have like and it is associated by the skin area, not inside the tooth. When the patient has other medical history and the pain is unilateral, he is over 50 years old, these combinations of the symptoms took us to this conclusion that we are dealing with a trigeminal neuralgia. These are hard to spell. Now for the case 2, let's see how the muscle pain actually is. The patient says that my teeth on the right side hurts, and it was a gradual beginning 2 years ago. Recently it increased. Now look, he's saying that the pain is actually really aggravated by opening wide, and this increases the intensity of the pain. When he bites, he's biting down. We said that biting is an indication for two things. It can be for periodontitis or for a crack. So let's continue. He said that he has another type of pain that is localized to the area of the right first molars, and it produces a sharp pain when he is biting. When examining the tooth, it has an occlusal amalgam with cracks evident on the mesial marginal ridge and the buccal groove. So we are dealing with a crack, but what about the other pain? The other pain was associated with the muscles of mastication. After palpation of the masseter, we found that the right deep masseter had a trigger point that caused this pain. So what the diagnosis was: reversible pulpitis secondary to a cracked tooth, and a muscle fiber pain of the right masseter are made. So the patient is giving home care instructions for treatment of his muscle pain, and he is referred to do a coverage, cuspal coverage, for both the tooth that had a crack. So hope you had an idea, a brief idea about how to diagnose and know the non-odontogenic toothaches that are usually associated with toothache. So they are they happen both contralateral, I think this is the word. Okay, see you soon. Salam. Pain is usually produced from tissue damage and is transmitted via nociceptors, C fibers, or A delta fibers. What are the A delta fibers? They have a faster conduction velocity than C fibers and are believed to transmit sharp sensation. C fibers have slower conduction velocity and are associated with a dull or burning sensation. Sources of odontogenic toothache: the pulp dentin complex and periradicular tissues. The primary nociceptors of the pulp that respond to inflammation are the slow-conducting high-threshold C fibers. They rarely terminate in dentinal tubules. Tissue inflammation decreases C fibers threshold. They can become so sensitized that they will fire in response to the normal pulse pressure of cardiac contraction, elicting a complaint of "I can feel my heartbeat in my tooth" or "my tooth is throbbing." Once inflammation from pulpal disease extends into the periodontal ligament, patients are able to locate the source of the pain much more readily. The sources of non-odontogenic toothache: the myofascial pain, which emanates from small foci of hyperexcitable muscle tissue. Clinically, these areas feel like knots and are termed trigger points. Pain is triggered by contraction of masticatory muscles rather than loading of periodontal ligament. Palpation of the muscles of mastication should reproduce the pain, whereas percussion of the teeth should not. The myofascial pain can mimic toothache, and toothaches may induce the development of myofascial pain. The therapy: deep massage, trigger point injection. The neurovascular pain: intracranial branches of the trigeminal nerve become sensitized. Most commonly, people report pain presenting in the forehead, back of the head, and they may have migraine. Individuals older than 50 years are more suspected to this pain with cardiovascular diseases or multiple sclerosis or brain tumor. The pain is intense, sharp, shooting pain that is most often unilateral and is not affected with stimulus intensity. Dental procedures can cause neural damage, like extraction, implantation, and certain toxic components of the endodontic treatment, like eugenol, sodium hypochlorite, formoclizol. Symptoms will not develop until 10 days, so quick management determines prognosis. Medical, which is medications, or in severe cases, the surgical treatment. Pain of sinus: symptoms of fullness or pressure below the eye, increases with patients lowering his head. Nasal discharge, nasal obstruction, and facial pain, pressure, fullness are few of the symptoms. Patients with suspected sinus nasal mucosal disease should be referred to an otolaryngologist for further diagnosis and treatment.